All right. So, welcome to 2026. This month we're going to be talking about symptomatic bradycardia, and I have a few different reasons that I decided to talk about this month. But we're revising the symptomatic bradycardia protocol. I'll be coming up in the next round, and I think I have prioritized this protocol because I think we have some issues with our management of symptomatic bradycardia as the protocol is written. I've been reviewing a lot of pacing cases and noticed that there are quite a few cases where we're pacing when it's probably not indicated. And then we have a real problem with false capture, which is not unique to our system. It's a problem everywhere. And we're going to talk about false capture towards the end. I did, talk about false capture, I think maybe in the first Tuesday series that we ever did. So some of you may have already heard some of this, but it's definitely still happening. And so I want to just have this on a recorded Tuesday series so that everybody can kind of hopefully view this and get a better understanding of why this is such a problem. The other reason that I wanted to talk about symptomatic bradycardia is that I've talked about this before, but we're moving forward with a new protocol that will be kind of a routine medical care protocol. And this will allow you all to perform an EKG at your discretion. So part of rolling that out, which will probably be mid-year that we'll roll that new protocol out, is that I think we need to have some more education just around EKG interpretation. So we're going to do a little bit of that as part of this as well, and in preparation for that. So kind of a few different things that I wanted to cover. Um, I think in order to talk about this, we have to do some review of cardiac physiology and anatomy. So the electrical conduction system, I know you guys have probably all learned this back in your anatomy and physiology in medical school, but I think it's important to understand this and review it. So remember that the heart has cells in it that have a characteristic called automaticity. So these are pacemaker cells, and those pacemaker cells are located at specific parts of the heart, and they all have their own intrinsic rate. So with the SA node, the AV node, you've got your bundle of His and then your bundle branches, and they all have their own intrinsic rates, right? So the SA node's rate is going to be about 75 to 100 beats per minute. The AV node is 40 to 60. And as you move down to the bundle branches and the bundle of His and the Purkinje fibers and the ventricles, those rates are slower, so 25 to 40. And so these cells have not only their own intrinsic rate, but they also have their own intrinsic conduction velocity. So how quickly those impulses are generated. And basically, whoever is fastest in this whole scheme and this whole electrical conduction system sets the pace, right? So generally speaking, that's going to be the SA node because it's fastest. It just gets there first. But if for some reason the SA node isn't functioning properly, then we have all of these other cells that can take over. So the conduction velocity is going to be fastest up in the SA node, and it slows down once we reach the AV node and down into the bundle branches. And so this actually has an impact on the appearance of the EKG because what happens is, our EKG is basically a reflection of the myocardium that's being depolarized, right? That's what we're looking at. And so our PR interval is basically when that impulse reaches the AV node, it pauses. There's a brief period of slowing through the AV node that allows the atria to complete their contraction, empty their contents into the ventricle, so they have a nice coordinated contraction, right? So um, all of this conduction velocity really does impact the appearance of your EKG. Um, and it impacts, whether or not you have a wide versus a narrow QRS complex, right? So depending on where that impulse is being generated, impacts how quickly it's being conducted. And so if you're above the AV node, at or above the AV node, you're going to have a narrow complex rhythm. I think you all know this. And below the AV node, or below the bundle of His, you're going to have a more wide complex rhythm. So just a really kind of basic review of why our EKG looks the way that it does. So we can change our conduction velocity, which is also referred to as dromotropy. We can change our chronotropy or heart rate, and we have lots of different factors that can impact these things. So vagal stimulation, we know, slows conduction through that conduction system. It slows the heart rate. Ischemia and hypoxia can have that effect. Certain kinds of electrical imbalances, electrolyte imbalances such as hyperkalemia can slow conduction, and then drugs like adenosine beta blockers can slow conduction. And then sympathetic stimulation, Norepi, epi are going to speed conduction. So we can alter these things with these different factors. Um, I want to briefly review AV blocks, and I know this is probably a review for most of you, but I just want to make sure that we're all kind of on the same page. So basically, an AV block is going to slow conduction through the AV node, slow or stop conduction through the AV node. And some of these blocks we care about a lot, some of them we don't care about at all. So first degree AV block, don't really care that much. So with this, you're just getting slowing through the AV node. This can happen just as part of normal physiology. It can happen in a normal, healthy heart. It's not necessarily a pathological thing. Sometimes it can happen as a side effect of medications. It can be caused by increased vagal tone. So lots of different factors can impact this, but generally speaking, this is not going to cause any symptoms. You can have like very profound prolonged PR intervals that might cause some mild symptoms or even maybe some severe symptoms. But generally speaking, this is a benign rhythm that we really don't care too much about. So you just have basically a prolonged PR interval. So not going to spend too much time talking about that. Now we have our Mobitz 1 block or a Wenke-Bucky's block. So not really considered generally a pathological or worrisome rhythm unless the patient is having symptoms associated with it. So with this, you're basically just getting slowing through the AV node. You basically get progressive fatiguing of the cells in the AV node that causes this progressive prolongation or pause at the AV node, progressive prolongation of the PR interval, and then eventually it gets so tired that it just drops a beat. This is kind of characteristic, regularly irregular, where you have this prolonged PR interval and then a random, not a random, it's a dropped beat at the end of the prolonged interval. It says usually a block at the AV nodes, you're going to have a narrow complex QRS associated with this typically. So this is just another example of that where you can kind of, if you march out your PR intervals, you can see it's getting longer and longer, and then you're dropping a beat. Okay, generally not going to worry too much about that unless the patient has symptoms. So that does not get me too excited. Now, when we start to look at a Mobitz 2 block, this is when things get a little bit more worrisome. And so here you have a static sort of normal PR interval that's occurring. You don't get prolongation of the PR interval, but then you just get a random dropped beat. Now, with your Wenke-Bucky's, that's more likely due to kind of a reversible cause, right? You might have that with even increased vagal tone. You might have that with medication side effects or ischemia. But with this, Mobitz 2, this is more commonly going to be due to like a structural problem. So you've got fibrosis in that electrical conduction system where you've got damage there that's causing random beats to just be dropped. So you're randomly not conducting beats. This is much more concerning because it can progress to a third degree heart block. And that, of course, is very worrisome. So this is an example of that. You can see you kind of have to look closely. This looks, you got to really look at the PR interval here, right? Because you are randomly dropping beats. But you can see that PR interval is the same before every QRS, and then you just randomly drop your beat. Okay, third degree AV block. I think everybody's familiar with what this looks like. You've got complete AV dissociation. The atria and the ventricles are just kind of doing their own thing. The P waves are marching through at their own rhythm, and then you have your QRS complex doing its own rhythm as well. So they're totally unrelated P and QRS complexes. And this obviously is very worrisome. So this is going to be more likely, again, due to a structural problem, like some sort of fibrosis, damage to the conduction system that's not reversible. So another example here, you can see that this is a very slow escape rhythm here, where you have very few QRS complexes on this 12 lead. So I'd be real concerned if I saw that. This is another example here. You can see your P waves marching through, probably best see them in AVL. And then your ventricular rate here is about 30, so really slow rate.
But one of the things that we are proud of in Santa Barbara County is
I'm gonna just mute whoever, somebody's not muted. Okay. So fixed ratio blocks similarly are also very concerning. So with a fixed ratio block, you're just dropping every other beat or every third beat or every fourth beat, right? So you've got a fixed ratio of QRS complexes that are making it through. The issue with this, if you've got a 2-to-1 AV block, you really can't tell if this is a Mobitz 1 or a Mobitz 2 just by looking at it because you don't have time for progressive prolongation. So A 2 to 1 AV block might be nothing, or it might be a Mobitz 2, and you might be more concerned. Again, also going to depend on the degree of symptoms that the patients have, but I'm going to be more concerned about this, right? And then a 3 to 1 block is going to be typically slower. You've got every third beat conducted. These are both 2 to 1 blocks that you're seeing on the screen here. Um, and then this one is super tricky. So if you look at this, I would, at first glance, if I wasn't really, trying to discern this, I would call this sinus bradycardia, right? Because it looks to me like, you've got a little bit of a prolonged PR interval here, but it looks to me as if you don't have any extra P waves, right? But if you look really closely, you actually have P waves that are buried in the T here. So this is a super tricky one, but that's just definitely one that would be more difficult to recognize, and you need a really good tracing to be able to see it. But you can see that you've got that extra sort of hump here buried in the T wave. Okay, and then a high grade AV block. Basically, this is a fixed ratio block of 3 or higher. This is a really slow rate. These patients are typically going to be symptomatic, and then obviously this is a cause for concern. I think here I think this is a 4 to 1 at the bottom. So every fourth beat is being conducted. Um, so here is another example where you can kind of, if you march out your P waves, you can see that basically here it looks like maybe every other beat isn't being conducted. So probably a 2 to 1 block that we're looking at here. Okay, so that was a quick review of blocks. Very briefly going to touch on junctional rhythms and idioventricular rhythms, and then we'll kind of get into the symptomatic bradycardia piece. So a junctional rhythm is a rhythm that's being generated either in the AV node or maybe bundle of His. So this is typically going to be a narrow complex rhythm. And because it's being generated in the AV node, depending on if the P waves are being conducted, and they might be conducted in a retrograde fashion, but they're not going to be conducted sort of SA node to AV node, right? So this typically in a junctional rhythm, you're not going to see P waves. They'll often be absent, but if they are present, they'll be inverted upside down, right? Because what you're seeing, if you do see a P wave, it's being conducted retrograde, basically from the AV node up through the ventricle. I'm sorry, up through the atrium. So you might see retrograde or inverted P waves especially in the inferior leads in a junctional rhythm, but oftentimes they just won't be present. Again, lots of things can cause this, just like all of our other blocks. Medications, ischemia, hyperkalemia is a pretty common one that can cause a junctional rhythm. So we'll see junctional rhythms quite a bit with hyper K. So always think about that in your dialysis patient. And then the terminology around junctional rhythms really just depends on the rate. So a junctional bradycardia is less than 40. Junctional escape rhythm is going to be sort of your intrinsic rate for the AV node, which is 40 to 60 beats a minute. And then you can have a junctional tachycardia or accelerated junctional rhythm. And this is just referring to where it's originating from again. So this is an example of a junctional escape rhythm, right? In this case, if you look at where your P waves are. So in most of your leads on your 12 lead, you do not have a P wave, right? So no P wave except in your inferior leads, so 2, 3, and AVF, you have an inverted P wave. And that's because of that retrograde conduction. So it's conducting from the AV node back up through the atrium. So you're just looking at it upside down, essentially. Okay, and then idioventricular rhythm, also known as a ventricular escape rhythm, it's going to be a wide complex rhythm. So this is, if you have sort of dysfunction somewhere up in your conduction system and the ventricles have taken over as the pacemaker, that is what you're looking at here essentially, right? So this is originating in the ventricle. You have a wide QRS complex and there's no P waves. You won't see retrograde P waves even in the idioventricular rhythm. It's going to be a really slow rate, so 30 to 50. Um, Obviously, this is going to be an alarming rhythm, right? So you can see this with a complete heart block, in which case you might see the P waves marching through. You can also see this not uncommonly in hyperkalemia, and then you can see this as like a post-arrest rhythm. Sometimes you'll see an idioventricular rhythm just immediately after ROSC because of the severe hypoxia and acidosis and stuff. So lots of things can also cause this as well. Okay, so brief review of rhythms. So now I want to jump into symptomatic bradycardia. This is from the AHA. This is their definition. And basically, we're talking about a documented bradyarrhythmia that's directly responsible for your symptoms. And that's the key here. the bradyarrhythmia itself is causing the symptoms, and the symptoms you are attributing directly to this. It's not an alternative, cause for it. And so we kind of know what those symptoms are, right? Syncope, near syncope, hypotension, altered mental status, severe chest pain, all of those things are symptoms that are manifesting directly from the bradyarrhythmia. And so this is going to be something that we are going to change. And I think this will be for the better. And so our protocol uses a cutoff of 60 beats per minute as our cutoff for bradycardia. Now, technically speaking, 60 is the cutoff for bradycardia, but when we talk about symptomatic bradycardia, we expect to see symptoms when someone's rate is less than 50. And to be honest, and you guys have probably seen this, you'll sometimes have patients with sinus bradycardia in the 40s who are totally fine without symptoms, right? But if you've got a patient with hemodynamic compromise, altered mental status, those patients typically aren't going to be, if their heart rate is in the 50s, that's not usually going to be the cause for their symptoms, right? So we're expecting this at a lower rate. And so we're going to change this cutoff to be 50 in the new version of the protocol to better align. This is also what the AHA sort of recommends. And I think just conceptually, this makes sense, right? We shouldn't expect to see heart rates in the 50s driving severe symptoms like that. Um, and I think this is sort of intuitive, but not all bradycardia is the same, right? So we have physiologic bradycardia. Lots of people have bradycardia that is fine, right? This is their normal rate. They're young, they're healthy, they're athletes. But even sometimes older people have a resting heart rate that's in the 40s. And I just had a guy like a couple of days ago. His resting heart rate is just in the 40s. That's where he lives. He has no symptoms associated with it. It's sinus. So we don't do anything about it, right? So not always pathologic. But there are, when we look at our pathologic types of bradycardia, there are some reversible causes that are important to consider. Sorry, one second. Sorry about that. I got a new dog and he's crazy and he just almost knocked over a plant. Okay. So our reversible causes, things like hyperkalemia, medication overdose, toxins, ischemia, and then we think about our structural causes, and that's things like sick sinus syndrome, which we'll talk about briefly, and then your complete heart block where you've got fibrosis and damage to the AV node or bundle of His or somewhere along the conduction system. So thinking about the history really matters in these cases, right? So it matters sort of what do we think the underlying cause is? Because that really does make a difference in our treatment. So, does this seem like a vasovagal event? Were they on the toilet and they passed out, right? Or is this a patient that's on multiple medications like clonidine and a beta blocker? So maybe it's just a polypharmacy kind of situation. Or is this a patient that's missed dialysis? We have to always think about hyperkalemia in these patients. So thinking about what could potentially be causing this, and then how long have the symptoms been going on, and sort of what's the history of the symptoms, right? So, and we're going to present some cases towards the end that just kind of highlight why this is so important. And it matters for our treatment, right? Because in some cases, it's going to be appropriate to go directly to pacing. But in some cases, you really got to think about giving other medications. You got to think about giving atropine and not going directly to that. So I think really thinking about the history is important for that. And then, of course, MI. When we move forward with the new protocol, we will have EKG in that protocol as sort of a standard expectation. Of course, once the patient is stable enough for you to do that, you don't want to be doing it in an unstable patient. But MI is definitely a potential cause for bradyarrhythmia. If you've got an inferior MI that's affecting the AV node or the SA node blood supply, then you can have a bradyarrhythmia associated with that. And then understanding what the underlying rhythm is and really looking at that and using that to help make your decision about your next steps, I think is also useful. Okay, so we've got some tools in our toolbox, treating the reversible causes, atropine, epi, transcutaneous pacing. These are kind of our tools for managing symptomatic bradycardia. And I should have put on here calcium because there are certain circumstances where that actually is going to be the best thing to give the patient. This is just from AHA guidelines. And you'll notice that the kind of number one treatment is addressing those reversible causes. And so we'll highlight this with some of our cases. And then, they do mention, and I think we will highlight this in the new protocol as well, but that, You can go directly to immediate pacing in some circumstances. It is appropriate in some cases, but those cases are going to be those patients who have a high degree AV block or a third degree heart block. Those are the patients where if they're unstable, you have a delay to getting atropine on board, those are the patients that you want to pace. The patients that you don't want to go directly to pacing are a sinus bradycardia, something that seems like maybe a vasovagal event. And I, in reviewing cases, have seen all of these patients directly go to pacing, and that's not what we want to be doing. So considering that, what type of rhythm you have before you go directly to pacing, I think is also appropriate. Okay, brief review of atropine and how it works. And I think this just helps us understand why maybe in some cases it's not as effective. So atropine is an anticholinergic medication that prevents acetylcholine action on the SA and AV nodes. So the vagus nerve releases acetylcholine that acts on your SA and AV nodes to sort of suppress things, right? It's a parasympathetic activity, right? So we're basically blocking that parasympathetic activity with atropine and increasing the rate in those cases. So we're increasing basically the activity of our SA and AV nodes by removing that parasympathetic activity. The dose of atropine, will be updating this in the new version of the protocol as well. So currently the dose is 0.5 milligrams. In our current protocol, we're going to update this to 1 milligram to be more aligned with what ACLS is recommending. And there's a reason for this. So um, there is some suggestion, although the literature on this I don't think is super strong, but there is some evidence that lower doses of atropine actually may paradoxically slow the heart rate. Now, we're talking about lower doses than 0.5 milligrams, but I think in light of that potential, I think it makes sense to just go with 1 milligram. Um, so we're going to be updating that. And, the max is generally considered 3 milligrams, and that's because if it isn't working by then, it's probably not going to work. Um, there are a few important contraindications. The most important is that heart transplant, we don't see a lot of heart transplant patients in this region. But it's important to know when a heart is transplanted, the vagus nerve is generally denervated, so it doesn't have that vagal stimulation, so it's not going to be effective, and it actually can cause sinus arrest and AV block. So it's definitely contraindicated in patients with heart transplants. And then, if you've got a patient with hypothermia, and this is, I guess, really just goes with any reversible cause that is not due to vagal stimulation, it's contraindicated. But certainly in bradycardia due to hypothermia, it's not indicated in that circumstance. So I think we all have learned that we like atropine for a complete AV block probably isn't going to work, and that's true because of the way that it acts, right? So it's not it's acting at the SA and the AV nodes, and so if you've got a block that's below the bundle of His, it's probably not going to be effective, right? Because you can inhibit that parasympathetic activity all you want. That doesn't change what's happening downstream. But that being said, it's still recommended as part of ACLS to try it if you have access. And so I can't say that I've seen it work in complete AV block, but it isn't going to hurt things in that circumstance. So I think it's worth a try. But that is maybe one circumstance where you could go directly to pacing, especially if you don't have an IV. Okay. This is just from the AHA, the recommendations for temporary pacing for sinus node dysfunction. So this is patients with like a sick sinus syndrome or other sinus node problem. And so um, basically, if you don't have significant symptoms, pacing is not indicated. And that's kind of the long and short of this. And then transcutaneous pacing can be used as a bridge if medications aren't working, essentially, is the long and short of that. So one of the things I really think it's important to cover here is false capture and pacing problems. And I apologize. I know some of you may have already heard this before, but I think it's worth revisiting because this is a huge issue in EMS. False capture is ubiquitous. And I'll show you some studies that demonstrate that. So first, failure to capture, I think one thing to recognize is that transcutaneous pacing just isn't that effective. So about 25% of the time, I would expect that you won't get capture. It just doesn't work that well. And there's a lot of reasons for that. It could be the pad placement. The patient just might have a lot of breast tissue or adipose tissue. Pad skin interface might not be great. So for lots of reasons, it's difficult to get capture with transcutaneous pacing. So just expect that it might not work. So that's one thing to know. Troubleshooting this, looking at your connections, making sure that you have good skin pad interface, replacing your pads if needed. Generally speaking, AP pad placement is preferred because you're going to get better transmyocardial current that way. But your pad placement really matters because air in the lungs is a crappy interface for transmitting electric. It's not a good conductor of electricity, right? So trying as best you can to avoid the sternum, avoid the vertebrae, but so just going to the left of the sternum and but capturing as much of that myocardium as you can. Um, and then recognizing that you might need a lot of energy to actually get capture. So um, the average is about 60 to 100 milliamps. So just recognize that if you haven't achieved capture at 80 or 90, you might need to go up, right? And that's perfectly fine. Especially, depending on the body habitus of the patient, you might need more energy. Okay, so false capture. This is also referred to as pseudo pacing or echo distortion or other names for this, but this is a really, really common issue. And what this is basically just electrical artifact. So this is Stryker is one of the few manufacturers that actually recognizes that this is a problem, but this is an issue with every monitor. And so what happens when you pace a patient is you're delivering a huge amount of electricity, right? And so when you deliver that electricity, the monitor just has to basically blank out a period of time so that it doesn't distort your image to the extent that you can't even see if you have capture, right? So the monitor basically closes its eyes for a very brief moment as that electrical impulse is being delivered to prevent that distortion from completely obscuring your ability to detect capture. It's about 40 milliseconds to 80 milliseconds is the blanked out period. This happens with every monitor. And what happens with this electrical artifact or false capture is that the monitor just opens its eyes a little bit too soon. And so what that results in is these sort of funky looking beats that are artifact. These are not real capture, even though they look like it, right? So they're rhythmic, they follow every pacer spike, but they are not capture. And there's a couple of ways that you can differentiate this false capture from a true capture beat. So first, just if you look at the appearance of this rhythm and really scrutinize it, it doesn't look normal. So the downslope here is almost vertical. It is vertical or almost vertical. So it's a very, very steep downslope, followed by a very, very steep upslope, rather than having like a wide slurred QRS complex like you would expect with a true capture beat. And I'll show you some examples of that in a little bit. The other thing to look for is the T waves. And so you will have either sort of a nothing burger, unimpressive T wave or no T wave at all. And if you have true capture, you should see a broad, tall T wave following every wide QRS complex, right? The other thing to look for is you have these native beats that are interspersed throughout the rhythm, right? And these native beats are falling right in where the T wave should be. And I'll talk about this again in another slide, but that's physiologically impossible, right? Because there's an absolute refractory period that is occurring at the time that that T wave is supposedly occurring, right? So you cannot generate an impulse during that time. So this, even though you might look at this and say, great, I've got capture, let me check a pulse, this is not capture. In fact, if what you might need to do in this case is keep going and increasing your energy until you get real capture, or you just might not be able to get capture. So these are some examples of what we call phantom complexes. These are, again, artifact, right? So all of these have that same characteristic appearance of a very steep downslope. The amplitude of this might differ depending on your lead. But you have a very steep downslope followed by a sharp upslope that does not look normal. And there's no normal T wave. Okay. And then this is another example of those native beats marching through. So you have pacemaker dissociation, right? So this is a nice one on the top because you can see that native beat, that native bradycardia, right? And then they begin pacing here. You think, oh, maybe I've got capture already, but you can see that those native beats are marching through, right? and they're in the absolute refractory period. And again, this is another example on the bottom. The P's are the pacer spikes, the N's are the native beats, and they're marching through in a way that is not physiologically possible. Okay, and then that's that absolute refractory period. So looking for that can be another clue. You can get pseudo fusion where it can be a little bit misleading because you have a native beat that's fusing with that electrical artifact and it makes it look like you've got a T wave. So those pseudo fusion beats can be really confusing, but they shouldn't be every beat. So just recognizing that that can occur. The other thing to look at is the amplitude of your QRS complexes. And so this is an example. This patient is being paced at 110 beats per minute and 200 milliamps, right? And so you might look at this and think, that looks pretty good. But if you scrutinize it more carefully, these are bizarre looking, right? These do not look like real wide complex um, QRSs. And then one clue is that this is the same patient. So the initial um, pacing energy at 80 milliamps. You can see the amplitude of the QRS complex here is not very tall. And then as you increase, your amplitude increases. And if you think about it, that doesn't make sense, right? Because what the QRS is reflecting is the volume of myocardium that's being depolarized. That volume is fixed. It doesn't change no matter how much energy you deliver. So if you truly have capture, that that QRS complex is shouldn't change. It should stay the same, right? So you shouldn't see the amplitude of the QRS change. And this is another example. Same patient at 40 milliamps, at 60 milliamps, and at 90 milliamps, you can see the amplitude is increasing. That is not capture. Okay, now contrast that to true capture. So you can see you have a nice wide QRS and then the tall, broad T wave, right? So definitely a different appearance. And it can be tricky. It's not easy to distinguish, but I think the most important thing is recognizing that this occurs. That's definitely the first step because this is something I never learned about until I started reviewing these cases. And so I think, and it's not something that we are often taught. So this is an important thing to recognize. This was a study that was just published back in November out of Seattle. And I think this is a really interesting study because it highlights how difficult it is to really determine if you have true capture. So they looked at a case series of 56 patients that were being transcutaneously paced, and they looked for either intermittent capture or complete capture, meaning they had capture throughout the period of pacing. Um, and then they had so that electrical capture occurred in 32% of cases, right? So I said before, expect capture in 75%. Well, it actually might be much lower than that. So 32% of the time they had capture, and they only had complete capture, meaning capture throughout that whole period of being paced, about 14% of the time, right? And this is like a highly trained system. And this is, I mean, this is happening everywhere, right? The other interesting thing is that in this system, they audio record everything. So the monitors not only capture the rhythm strips, and that is reviewed, but they also have audio that is timed along with that. So as the paramedic is working, they're verbalizing things, and so you can hear in real time what's happening. And so they could listen and say, okay, the provider verbalized that they had a pulse. They verbalized, I feel a mechanical pulse. So they were able to look at the EKG strip at that time and determine that although providers thought they had a pulse, the capture was really only actually there 15% of the time. And so this highlights how difficult it is to confirm capture just by checking a pulse, because that impulse of that, especially if you're at a higher milliamps, you can actually get a little bit of skeletal muscle movement that feels like a pulse. It's very deceiving. It's very difficult from mechanical, palpating a pulse alone. It's very difficult to tell if you truly have capture. So I think that's just something that's important to recognize because if it's happening here in Seattle, it's happening probably everywhere else, right? One other really interesting thing about this study, and I'll show you another one that had the same finding, is that if you have real capture, you should see a better blood pressure. So when patients had capture, the blood pressure, systolic blood pressure was increased by 20 millimeters of mercury. When you don't have capture, it doesn't change at all. So you definitely should expect to see an improvement in your blood pressure. So that's also a very important clue. And this is a nice figure from their study that was recent, or their abstract that was recently published, that highlights some of the different types of capture beats. And so in green, you have real capture. Those are true capture beats. The boxes in red are that electrical artifact or that false capture. And then in blue, you have your native beats. So in the top bar in A, you can see that you've got kind of every other beat is true capture. Then in the bottom, you've got these periods of intermittent capture where you've got some capture beats and then they're losing it. So you can see that the QRS is wide. You've got a big T wave, right? So definitely different. And then you've got some native beats kind of along here. I think E is actually a really tricky one, but you can see the morphologic change in this slide on the bottom. So on the left, you've got a bunch of beats of electrical artifact followed by a definite change in the appearance of the QRS complex, and this is real capture. So this, I think, just goes to show how tricky this is to discern. But also really important to understand. So transcutaneous pacing is problematic. This is another study that was published back in 2023. Um, this article is really great. It's behind a paywall, but if anybody is interested, you can email me and I will email it to you. It's got just some good examples and education around false capture as well. So if you want to do further reading, just email me and I will send you this article. But so this was a smaller case series. They looked at 23 patients that were being paced. 19 of those 23 patients, nearly all of them had false capture. When those patients did have true capture, the blood pressure increased by 40 and they had false capture, it didn't change at all, right? So this is another example of this is just ubiquitous. And I've reviewed a lot of our pacing cases and I can tell you this is definitely happening here as well. Um, okay, so how do we confirm capture? So it's not enough to just check a pulse. I think that's been demonstrated in the last studies I just showed you. You get fooled a lot. You have to look for clinical improvement in your patient. So you expect to see an improvement in your blood pressure. You expect to see an improvement in mental status. If the bradycardia is truly driving that patient's symptoms, fixing the bradycardia should fix their symptoms, right? Another thing you can look for is you should see a pulse ox waveform that corresponds with every paced QRS, right? So in this case, you do not have that, right? So you have all these paced rhythms, but you can see that your pulse ox waveform, which is shown on the bottom, is much slower versus here, you have a pulse ox waveform that corresponds with every QRS. So this is a great proxy to tell you if you do or do not have capture. Now, sometimes I recognize that the pulse ox doesn't always work. But if you have it, this is a really nice way to confirm. And then again, clinical improvement. Okay, so I'm going to run through a few cases here that highlight just to kind of think about when we should go directly to pacing and when we shouldn't. So in this example, we've got a 78-year-old female. She's got dizziness and nausea. Family was with her when she had a syncopal episode. When you arrive initially, she's real tacky. She's AFib with RVR, a rate in the 130s. She's complaining of chest pain and nausea and dizziness. She looks terrible. And then she has a 4.5 second sinus pause. So brief period of asystole followed by syncope. And she's intermittently bradycardic. So she'll have periods of bradycardia in the 30s, and then she'll go into AFib with RVR. So what do you want to do for this patient? There's more than one answer that is correct, by the way. So high flow oxygen, absolutely, go for it. Give her some oxygen. Atropine, I might not reach directly for that unless the bradycardia is persistent. You know, this is a tough case. I think if she's persistently bradycardic, absolutely, I would give her some atropine. I probably wouldn't begin immediately transcutaneously pacing again, unless you have a persistent bradycardia that's unresponsive to medical therapy. Definitely, I'm going to put this patient on pads no matter what, because, you know, in case she arrests, in case she goes into a rhythm I can shock, in case I need to pace her, I'll be ready. Um, Probably not going to start her on an epi drip right now. So kind of the tools in our toolbox, close monitoring, pacing, and atropine if needed. This is sick sinus syndrome. This is not uncommon. We see this fairly frequently. This is it's age related, but I've seen this definitely in younger patients as well. But you get fibrosis of the sinus node at some of the surrounding tissue that results in irritability. So these patients can have periods of tachycardia followed by bradycardia. Um, and so they often will have an underlying AFib or flutter that's interspersed with these bradycardic episodes. These patients can have episodes of syncope. It can be very scary. Um, Management for these patients will often, depending on the degree of how symptomatic they are, they may try to first address the reversible causes. And then, if they're really symptomatic or persistently symptomatic, they may need a permanent pacer replaced. So this is a tricky one because they're kind of both tacky and Brady. Um, okay, then we've got a 48-year-old female complaining of nausea and vomiting. So this lady has been vomiting all day long. She feels like crap. She's got a little bit of belly pain. Initially, her vitals are pretty normal. She's got a normal heart rate. Blood glucose is okay. You're getting ready to transport her, and then she gets pale and diaphoretic. Looks like she's about to pass out. She's vomiting. You're repeating her blood pressure, and it's in the 70s. Her heart rate is 40. She looks terrible. And this is her rib. She's sinus bradycardia. So what do you want to do for this patient? Start a fluid bolus? Sure, I would totally do that. Give atropine, maybe. I think it's okay if you want to give this patient some atropine, if you can pull it up. I mean, basically, what is going on with her? She's having a vagal episode, right? And so it's probably going to self-resolve with a little bit of time, but it's not going to hurt to give her atropine, right? A vagal episode is due to increased vagal tone or vagal stimulation, so certainly not going to harm her. Um, Immediately beginning transcutaneous pacing, definitely don't do that in this circumstance, right? She's sinus bradycardia, probably a reversible cause. Probably not going to need an epi-drip, and I would definitely give her some Zofran, right? So in this case, going immediately to transcutaneous pacing is definitely not the answer. Okay, and then you guys are all familiar with situational syncope, vasovagal syncope. You get emotional stressor or some kind of increased vagal tone that causes this episode that slows the heart rate down, slows the blood pressure, causes you to pass out, and then you go back to normal, right? Typically, this will resolve with no interventions at all. Okay, so now you've got a 16-year-old who's presenting with altered mental status. You find a half empty bottle of clonidine. Patient is hypotensive, bradycardic, they are bradypneic, so really slow respiratory rate, and they're hypoxic. They're kind of barely responsive, just moaning to painful stimulus. You notice that they do have pinpoint pupils, and then their blood sugar is fine. This is their EKG. It is just a regular old sinus bradycardia, pretty slow rate. They're in the 30s here. So how would you manage this patient? Start an IV fluid bolus? Sure, I would do that. Give Narcan. So this is clonidine is a really interesting drug. So it's actually an alpha 2 um, sympathetic blocker, essentially. And so uh, it has the effect of slowing your heart rate and slowing your blood pressure, but it also acts on opioid receptors and it acts kind of like an opioid. So in overdose, it will cause respiratory depression and pinpoint pupils. So it's kind of an opioid overdose mimic, which is super interesting. But the patients will also be really low and slow with a clonidine overdose. So Narcan actually is totally fine to give in this circumstance, and it will probably help. It will transiently improve their respiratory rate and mental status in some cases. So definitely giving Narcan is fine, totally appropriate. Giving atropine is fine also. I don't think it's wrong to try some atropine in this case. It may or may not help, but I probably wouldn't go immediately to transcutaneous pacing until I've done some of these other things and tried to reverse if the patient's really unstable. You can pace this patient for sure, but I would try the medical things and reversible causes first for sure. And then obviously putting them on oxygen is appropriate. Okay, so lots of medications can lead to slowing or bradycardia. Let me just see our chat here. Bag them. Yeah, Kurt. I didn't put that on there, but yes, you should probably bag them too. Okay, so yeah, lots of drugs on here can make bradycardia worse. So beta blockers, calcium channel blockers, clonidine, as I already mentioned. Some of your antiarrhythmics, probably the only ones that we'll see is like amiodarone. We've got some folks on that. Flecainide sometimes. These other sometimes, we've got occasionally we'll see people on these other antiarrhythmics, although I'd say less commonly. Some of our psychoactive medications like SSRIs and tricyclics can sometimes cause bradycardia and overdose, and then digoxin is another one that you might see. So just recognizing that in a lot of cases with these overdoses, your treatment is going to be, in some cases, we have antidotes like in a beta blocker overdose, we're going to reach for glucagon, calcium channel overdose, we're going to reach for calcium before we move on to those other things, right? So just thinking about that. And I think in overdose cases, it's never a bad idea if you have time to contact base because there are sometimes weird antidotes that we can kind of help you work through for some of these overdoses. Sometimes not. Sometimes it's just supportive care, but it's worth a call in because like glucagon for beta blocker overdose is an example of one that's kind of weird that you might not think about. Okay, so in this case, we've got a 54-year-old complaining of fatigue and altered mental status. This patient is a dialysis patient, has CHF and diabetes, and you get the extra history that they missed dialysis a couple of sessions. Their heart rate is in the 30s. They look terrible, lethargic. They're kind of intermittently talking to you. Their sugar's fine, it's high. This is their EKG, so I'll give you a sec to look at that. And what I see is no P waves, right? I do not see any P waves here. This is a slow bradycardic rhythm. This is a junctional bradycardia. Um, and so in this case, management might not start IV fluids depending on how their fluid status looks. They're not hypotensive, so I'll probably skip that for now. I would place them on some oxygen. Um, Atropine, that would not be the first thing I would reach for. I would not begin transcutaneous pacing immediately. I would contact base for calcium, right? So I think we really underuse calcium in our system, and we have so many dialysis patients. If you've got a patient with a junctional rhythm that missed dialysis, they need calcium. That's what they need to correct their rhythm. So consider that always as a potentially reversible cause. And you'll be surprised at how quickly after you give calcium, their rhythm goes back to normal. It's really kind of remarkable. So it actually, remember, calcium works to stabilize the cardiac membrane in hyperkalemia. And so you will get correction of the rhythm. If that failed, then maybe I would, potentially consider moving on to atropine and maybe pacing depending, but I would certainly be trying to correct the hyperkalemia first. Other things that you have in your toolbox for hyperkalemia, just to think about, it's not going to be probably on the protocol, but you can always talk to base if you feel like it truly is hyper-K, is albuterol. So we have high-dose albuterol, and that just shifts the potassium into the cells. And then sodium bicarbonate is another way to shift potassium into the cells. So sometimes if someone's really hyperkalemic, we'll do all of those things. We'll shift them and then we'll also stabilize their cardiac membrane. Okay, we're almost done here. So this case is a 77-year-old male who is coming in with severe respiratory distress. So BLS is first on scene. They find this guy, he's just like severe respiratory distress, breathing in the 40s. His SATs are in the 70s. He's real tacky initially. They put him on high flow oxygen, but he's continued to just deteriorate despite being on a non-rebreather. And then by the time you arrive, he's basically unresponsive. He's being bagged. He's got agonal respirations, a weak pulse. His heart rate is 36. He is probably dying, right? So you have your EKG here, and it looks like he's in a sinus bradycardia. You put him on the monitor. And so how do you want to manage this guy? Insert Nigel and ventilate him with high flow O2. I think that's probably a good idea. So try to improve his ventilation, improve his hypoxia. Place the patient on pads and get ready to do compressions. Yes, I think that's probably also a good idea. Give atropine. I would probably anticipate that this guy's about to code, right? So I think thinking about atropine and beginning transcutaneous pacing, I would try to correct his ventilation first. And the concern with beginning transcutaneous pacing immediately on this patient is that he's circling the drain. He's in this bradycardic death spiral and he's about to die. So what happens if you start pacing him in this state and he codes, he goes into asystole, and you have false capture? How are you going to recognize that anything has changed? If he's a GCS of 3 and you're pacing a corpse, it's very difficult to tell if his rhythm has changed if you have that false capture. So I would be really, really cautious about pacing this person right off the bat. Um, that's not to say that you absolutely can't pace somebody who is bradycardic and unresponsive, but it's real tricky because the last thing you want is to bring in a dead person being paced, right? So really important to think about, is this patient just about to code? Is this really the appropriate time to start pacing? And I say this because this happens, right? This happens where people don't recognize that the patient is actually in asystole, and that's because of that electrical artifact fooling you into thinking that you are actually pacing the patient successfully. And if you do decide to pace this patient, you should be dang sure you have some clinical improvement with it. You should expect to see an improvement in their mental status. You should expect to see an improvement in your blood pressure, right? So this is a tricky, tricky case. Okay, last but not least, you've got a 38-year-old male found down outside with altered mental status. The ambient temperature is 30. It's cold. He's cold. He's a GCS 11, kind of not responding very well. He's bradycardic to 48. You can't really get an SpO2 reading because it's too cold. Um, and this is his EKG. So you've got a rate, I don't know, in the 40s, high 40s. And then what you can see here is you've got these Osborne waves. That's what that red arrow is pointing to. So this is a characteristic finding in the EKG of a hypothermic patient. So what do you want to do for this guy? Give atropine? No, we're not going to do that, right? We are not going to begin transcutaneous pacing this patient immediately, because we know he's got a reversible cause. Like we know, we can say, I think this is hypothermia. So the treatment for this is rewarming. If you have warm fluids on the rig, give warm fluids, crank up the heat, put him on the monitor and gently transport him, right? We don't want to, there's a risk of, if you move the patient too much, you may precipitate an arrhythmia. So gently transport them. Pacing is not going to be, is not indicated in this gentleman. Okay. Oh, sorry, I lied. There is one more case. Okay, so this is a 70-year-old female with chest pain, nausea, and dizziness. She's intermittently been experiencing this throughout the day, and now it's kind of constant. She feels like she's going to pass out. Has a history of some coronary artery disease, hypertension, diabetes, is on a multitude of medications, including amlodipine, a calcium channel blocker, and then metoprolol, a beta blocker. She looks awful. Her heart rate's in the 20s. Her blood pressure is in the 80s. And this is her EKG. So let me take a look. And I see a complete heart block here, right? So this case, how would you manage her? This is the case where maybe you just go ahead and start transcutaneous pacing her, right? So you've got a high degree AV block, you've got a third degree block. That's obviously what is causing her underlying symptoms. So I would definitely put her on high flow O2. If you have access, you can go ahead and get her some atropine while you're setting up for pacing, but I would expect that you're probably going to need to pace her, and probably sooner than later. Totally appropriate to start pacing this lady right off the bat. But this is really, in all of those cases that we went through, this is the only circumstance where I am going to go directly to transcutaneous pacing. Even if the patient is unstable, I'm going to try to give meds first or try to find a reversible cause first. I mean, part of the reason for that is that, as I mentioned, transcutaneous pacing is difficult and you get this artifact. It's not necessarily a benign intervention. If you need to do it, absolutely, you need to do it. And sometimes you might not get capture. But I think because of the challenges with this, it's best to sort of work on your reversible causes before you go directly to it, unless you're in this circumstance with your patient with a third degree block. Okay. Um, so quick summary here, kind of already went over this. Going directly to pacing is usually not the answer, except when it is, like in our last case. Be really vigilant. False capture is so common and so pervasive. You really have to use multiple methods to confirm that you have capture. And the most important thing to look for is clinical improvement, improvement in your blood pressure, improvement in your patient status. Use your pulse ox. The femoral pulse is going to be the best place to check a pulse. Carotid is probably, you're going to feel those skeletal muscle contractions more commonly. And then really scrutinize your rhythm for false capture. And then these are just some great resources out there. EMS 12 lead is awesome. They have a whole bunch of articles about this false capture. It's really, really well done. And a lot of the, some of the images that I have in there with the false capture are from that website. So they have multiple sort of blog posts on this. So I definitely recommend checking out that website if you want to read more. The Joshua Kimbrell article is the one I mentioned that I'm happy to send you if you want to email me. I'll put my email in the chat. I think you guys, most of you have it, but I'll put it there. And then Stryker put out a clinical paper that explains this also a little bit more. And then that's your CE there. Um, Yes. So, third degree, no atropine, only transcutaneous pacing. So, I think if you have access and you can give atropine quickly, go ahead and give it, even in a third degree heart block. Because depending on the location of the block, you may have some effect, and it's not always easy to tell exactly where your block is. So, I think it's worth a try recognizing that it's probably not going to work. And if you have a delay to pacing in a super unstable patient, it's totally fine to go directly to pacing. But if you have access, give the atropine first, while and then you can go ahead and set up your pacing and do that, if that makes sense. Yeah. Um, all right. That is the end. Let me throw my um, email in here in case anybody wants to reach out. All right. I am going to stop recording here. And if anybody has any questions or comments, um,